This lecture is going to be Chapter 9, Part C. This is the last section for Chapter 9. Alright, aids to airway management. Alright, the oropharyngeal airway. It's a plastic device inserted into the mouth and keeps the tongue off the back of the throat. Only used in unresponsive patients that do not have a gag reflex. They come in multiple sizes to fit infants, children, and adults. This is an image of an individual opening the patient's mouth with the crossed finger technique. Alright, these are some of the different sizes they come. As you can see, they come very small sizes all the way up to, standard adult size. This is how you measure the airway. We'll go over this more in class as well. Alright, so you're going to insert the airway with the tip pointing towards the roof of the mouth. When halfway in, you rotate 180 degrees. The flange should rest on the outside of the lips and never any further than the teeth. Alright, an alternative insertion method is 90 degrees into position. You insert the airway sideways and then rotate it 90 degrees. Another method is to use a tongue blade. So you just depress the tongue and then insert it in its normal position.
The oropharyngeal airway flange rests against the lips. The rest of the device holds the tongue as it curves back to the pharynx. Carry a complete set to ensure the proper size, which extends from the mouth's corner to the earlobe's tip. Place the patient on their back and perform a crossed finger technique. Position the airway's tip so that it points towards the roof of the mouth. Slide the airway along the roof of the mouth past the soft tissue, uvula, or until resistance is met against the soft palate. Gently rotate the airway 180 degrees so that the tip points down to the pharynx, which prevents pushing the tongue back. On an infant or child, insert with tip pointing down toward the pharynx, using a tongue depressor to press down and forward. Ensure that the flange is against the lips. Place the mask over the in-place airway adjunct. If there is a gag reflex, remove the adjunct at once, following the anatomical curvature. Some EMS systems allow an oropharyngeal airway to be inserted with the tip pointing to the side of the mouth. The device is then rotated 90 degrees so that its tip is pointing down to the pharynx. The nasopharyngeal airway is used when there is a reduced level of responsiveness but still a gag reflex, or when the teeth are clenched and there are oral injuries. Measure the airway from the nostril to the earlobe or the angle of the jaw. Apply a water-based lubricant. Gently push the tip of the nose upward. Keep the head in a neutral position. The bevel or angled portion at the tip should point toward the base of the nostril or toward the septum. Insert airway into the nostril. Advance until the flange rests firmly against the nostril. If you experience blockage, try the other nostril. Materials that remain in the airway may be forced into the trachea or lungs, which can cause complications including pneumonia and airway obstruction. Suction when gurgling sounds are heard before, during, or after artificial ventilation. Put your finger over the proximal port. Suctioning begins from the distal end. Place the catheter where you want to begin suctioning and suction on the way out. Alternate suctioning for no more than 15 seconds with ventilating for 2 minutes. With suctioning, always use appropriate infection.
Nasopharyngeal airways, or NPAs. They're flexible tubes inserted into the nose to create a clear and open path for air. This is the preferred choice when the patient is not unresponsive or they have a gag reflex. If they're conscious, they're still not going to like it, but they can tolerate it. Alright, NPAs are easy to insert. They come in numerous sizes just like the oral airways do. If indication of head or facial injury, you don't want to insert an NPA. You could have some type of basilar skull fracture, and the NPA could actually wind up in the patient's brain. We'll go over that more when we get into the trauma section, but just don't put them insert a NPA if you've got a suspected head injury. This is what they look like. Um, the ones on the right hand side are generally the most common, but they're all very effective. Alright, this is how you're going to measure it. We'll go over this more in class. Right, this is them applying a lubricant to the airway to make it be able to be inserted into the nares a little bit easier. Right, so you're going to gently insert it into the airway, advancing until the flange rests against the nostril. Right, again, this is just showing how it's supposed to be inserted. Bag mask ventilation. Assisting inadequate or apneic respirations. So you're going to use a self-refilling bag, valves that control one-way airflow, and a face mask. It can be used with or without supplemental oxygen. Comes in sizes for infants, children, and adults. Infection control barrier between you and the patient. This is some different size BVMs. The one on the top is for adults. One in the center is for children. The one on the bottom is for infants. These can all be used with or without supplemental oxygen. Alright, two rescuer bag mask ventilation. This is probably the easiest and most common way to use it. The first rescuer uses two hands to maintain a good mask seal, and the second rescuer squeezes the bag. Having somebody to focus solely on maintaining a good seal is so important. It's hard to maintain a good seal on individuals that we're generally dealing with. Most of the time, they're not going to have the easiest airways to manage, so having an extra set of hands is very important. This is going to demonstrate two rescuer bag mask ventilation. Alright, note the proper hand position. And obviously you can only use this when there's two rescuers. Alright, one rescuer bag mask ventilation. For a single rescuer, bag mask device can be difficult to maintain a mask to face seal with only one hand. This is the best technique to maintain a good seal. Like again, sometimes it's not very effective, but when you're by yourself, this is generally the best method. Alright, this is an alternative method. If you have smaller hands especially, you can place the bag on your leg and then press it with your other hand. You just got to be careful not to deliver too large of a volume, because you can definitely overinflate someone's lungs with the bag valve mask. Alright, suction systems assist keeping the patient's airway clear. They can be manually powered, oxygen or air powered, or electrically powered. This is a image of a oxygen powered portable suction unit. These aren't very common. You're generally going to see either a manual or an electric suction. This is manually operated suction device, or a VVAC. They're very effective. They're able to get large chunks of vomit out of the airway. To me, they're one of the most effective suction devices available. This is a battery powered portable suction unit. That's what we use at work. They're pretty effective. Um, they are not as effective as the manual ones as far as I'm concerned, but they do not require any manual power to operate them, so that is a benefit. So the suction unit installed in the ambulance patient compartment. This one also appears to be portable. If you'll note the handle. Alright. Thick walled, non kinking, wide bore tubing, unbreakable collection container, sterile disposable, semi rigid but flexible or rigid suction tips. These are all components of a good suction system. You got to use proper BSI precautions. Keep suctioning time to a minimum. 15 seconds for an adult, 10 seconds for a child, 5 seconds for an infant. If copious fluid in the patient's airway, roll onto the side and then suction. That's what we were talking about earlier, putting them in a uh, lateral position to allow the airway to clear itself naturally with the help of gravity. Then you can suction any additional items that need to be suctioned out of there. Measure the suction catheter before inserting into the patient's mouth. Activate suction unit only after completely inserted, then withdraw the catheter. Twist and turn tip of catheter, removing it from the mouth, the nose, or the stoma. Concentrate on the back corners of the mouth. Check the function of the suction unit prior to using. So just test it with your hand. Make sure you're actually producing suction. For oral suction, insert the tip of the device only as far as you can see, then initiate suction. You respond to a college dorm for an unresponsive 18-year-old female that, according to roommates, has been drinking all day. You open the airway and begin to place the OPA, but she has an active gag reflex. What do you do? So you want to stop what you're doing. You don't want her to vomit because it could cause her to aspirate, and that causes a lot of issues we don't want. If her airway is clear, you can try to ventilate without the oral airway. Next thing you're going to want to look at is to move into using a nasal airway. If she'll tolerate that, she probably will be able to. While ventilating, the patient begins to vomit. How long should you suction? Alright, so if it's an adult patient, we're going to suction for no more than 15 seconds. If it's a child, we're going to suction for no more than 10 seconds. And if it's an infant, we're going to suction for no more than 5 seconds. Alright, let's summarize Chapter 9. Respiratory compromise caused by asthma, bronchitis, drowning, choking. Clinical death occurs at the moment that both the breathing and heartbeat stops. Biological or irreversible death occurs approximately 4 to 6 minutes following clinical death. A patent airway is open and clear. The air we breathe contains about 21% oxygen. Signs of inadequate breathing: increased work of breathing, shallow, rapid, noisy, or gasping breathing. Provide rescue breaths using appropriate barrier device and use firm seal with the mask. Causes of airway obstruction can include the patient's own tongue, which is the most common airway obstruction, blood, saliva, foreign objects. Provide immediate care for the removal of the obstruction. The preferred method for opening the airway of an unresponsive patient who is not injured is the head tilt chin lift. The preferred method for an unresponsive patient with suspected neck or spine injury is going to be the jaw thrust. If you're unable to open the airway using the jaw thrust, attempt the head tilt chin lift maneuver. You've got to get to the airway, so even if they do have some type of possible neck or spine injury and you can't open their airway, With the jaw thrust remover, go ahead and attempt the head tilt chin lift. Unresponsive patients with no gag reflex should receive an OPA or oropharyngeal airway. For patients with a gag reflex that are somewhat responsive, an NPA or nasopharyngeal airway is the best choice. When a patient is not breathing adequately or not at all, provide positive pressure ventilations or rescue breaths. Best sign that you are providing good rescue breaths is good chest rise and fall with each breath. To minimize flow of air into the stomach during rescue breaths, provide slow, even breaths. Do not overinflate the chest. If the patient's airway becomes obstructed with fluid, saliva, blood, or vomit, it will be necessary to suction the mouth and or nose to remove fluid and clear the airway. Alright, let's go over some review questions. What is the oxygen concentration of room air? Alright, so just always keep in mind room air, ambient air is what we're breathing, and that is 21%. What are some common causes of respiratory compromise? It can be trauma, it can be disease processes. What is the difference between clinical and biological death? Clinical death is the moment that the heart stops beating and the individual stops breathing. Biological death is also referred to as irreversible death and occurs generally 4 to 6 minutes after clinical death occurs. What are the signs of a patent airway? That's just going to be an open and clear airway, guys. They're breathing in and out, adequate chest rise, patient's just breathing normally. What are the signs and symptoms of adequate versus inadequate breathing? The most clear sign is going to be adequate chest rise and fall. What are common causes of airway obstruction? The most common is the tongue, but it can be any foreign object that's entered the mouth. It can be swelling from anaphylaxis or an infection. It can also be from trauma. You can have deformities that cause the airway to become obstructed. What are the signs and symptoms of a partial and complete airway obstruction? So somebody with a partial airway obstruction is generally going to be conscious. They may be actively choking or coughing. Somebody with a complete airway obstruction is going to be grasping their throat. They may be attempting to cough or speak, but no noise is going to be produced. How would you care for a patient with a partial and complete airway obstruction? So an adult with a partial airway obstruction, you're going to try to get them to continue to cough and try to remove the obstruction on their own. If they become completely obstructed, you're going to move into abdominal thrusts and or the Heimlich maneuver. You're going to do that until they become unresponsive. After they become unresponsive, you're going to start CPR. It's going to be the same for a child. An infant, you're going to perform back slaps and chest thrusts. How do you best manage a patient's airway when there's a suspected spine injury? It's always going to be the jaw thrust. If for whatever reason you attempt a jaw thrust and you can't open the airway, you're going to go ahead and attempt the head tilt chin lift. We've got to be able to open our airway.
control practices. If gagging begins, withdraw the tip to a position where gagging stops.